Well, good morning. My name's John Zweifler. I'm a medical consultant with the Fresno County Department of Public Health, and I'll be speaking about naloxone, but I wanted to do some basic background information as well. And so some of it really borrows heavily from the Department of Behavioral Health, so it may be old news to you, but we can go through those sections more quickly. So. First of all, why are we talking about naloxone? Well, because we've seen drug overdose deaths increasing in the United States rather dramatically. During the time of the pandemic, uh, uh, between 2019 and 2020, there was a 20 to 30% increase in deaths, and then another jump um, uh, in 2021 from 91,000 up to 107,000. So really pretty rapid increase in total overdose deaths in the United States. So includes not only opioids and fentanyl, which we'll talk about specifically, but also stimulants as well. And we're seeing it across the board in terms of different races and ethnicities. There's particular interest in our community and nationwide, I would say, in the impact of opioids and fentanyl on our youth. And we've seen an almost doubling in the overdose death rates in teenagers over the last couple years. So pretty dramatic increases. This is, health equity is also an important issue, and this particular slide. Let me see if I can get a pointer going here. Okay. Um, this just shows that the increase in deaths is occurring in all populations. Use of Narcan relatively stable in all populations. But I thought this was an important and rather telling statistic. If you look at who gets into substance use disorder treatment programs, if you're white, you're twice as likely to get in as if you're black. Health equity is an important issue, and one that I think we all just kind of need to remind ourselves. And sometimes we see these kind of stark disparities in the services that we provide. We were talking about drug overdose deaths in general, but focusing specifically on opioids. So this is a kind of a complicated slide, but I'll just walk through it. So this breaks down the opioids in terms of synthetic opioids, so particularly fentanyl, and comparing it to things like heroin and to methadone. And so what we're seeing is that there's a big increase in the synthetic opioid deaths. So particularly fentanyl. So we see the rate increasing almost 50% between 2019 and 2020. On the other end, up to as almost 18 per 100,000. As you compare it to heroin, where the rates have been staying pretty stable throughout over our recent history. Looking at prescription drug overdoses, again, fairly stable. Methadone, lower numbers, again, fairly stable. So really the increase is being driven by the increased availability of fentanyl, which is probably related to the fact that fentanyl is 50 to 100 times as potent as the other opioids we generally use. One way to think about it is we measure fentanyl doses in micrograms. We measure things like Vicodin, Norco, other opioids in milligrams. So there's 1,000 micrograms in each milligram. So that gives you some idea. It gets a little confusing because even though it's more potent, it may be cut in different ways. So what actually gets to the individual varies incredibly by how it's prepared, particularly with the illicit drugs that are out there. But it does show that just a very little amount can be potentially fatal. Um, we're mainly focusing on opioids, but stimulants are a major issue as well. And so we see again these significant increases over the last several years. Um, uh, uh, and I was going to turn now to talk a little bit about Fresno County. I think that's another slide that looks more at the stimulants there. So if you look at our overdoses here in Fresno County, so we follow the national trend of anything even more dramatic. So our accidental overdose deaths increased from 160 to 250. So over a 50% increase during that time period. When you break that down, our rates of overdoses are actually the one that's the most concerning is methamphetamines. 77, fentanyl 7, morphine 9. That was in 2019 and then 2020. So we see a big jump in fentanyl deaths, but also in methamphetamine. So if you compare that to what we saw nationally, the impact of methamphetamines in our community is actually, in terms of overdose deaths, is actually more dramatic than opioids, and whereas nationwide that is reversed. That really opioids have more have a higher rate of death than stimulants. This just digs into that data a little bit more, so you can use it as reference. A lot of people use not a lot of people, but individuals with opioid use disorder are often using both methamphetamines and opioids together, also mixing with alcohol. This just summarizes that. So in addition to deaths, opioids also have a big impact on our healthcare system. So opioid use and alcohol, both major drivers for ER utilization, hospitalizations, and readmissions. Nationwide, 1 in 9 hospital admits related to substance use disorder. So really dramatic, similar data for California. I work with a medical group, and we look at hospital discharges, and probably not surprising to all of you, it's often very difficult to contact individuals with substance use issues, and so providing case management services is a particular challenge for this population. So, turning to naloxone, so what can we do if someone has an overdose? And the main thing we can do is, well, first of all, you call 911 to get some help. But the other is that we do have a very good antidote for opioids, and that is naloxone. So, naloxone is an opioid antagonist. It's sold under the trade name of Narcan, and it's indicated for drug overdoses. So how do we know if someone has an overdose? Well, a couple, probably the two biggest ones. First of all, they're just unresponsive or very minimally responsive, breathing very slowly or not breathing at all, and a kind of a specific for opioids, a very small or pinpoint pupils. So that combination of small pinpoint pupils and their slow breathing or unresponsive, and particularly in a setting where opioid use is suspected, then you're most likely dealing with an overdose. So what do you do? Well, you can give them Narcan. We'll talk about how to do that. But again, contacting 911 as soon as possible is the other consideration. Uh, so this just talks about Narcan use by our EMS system. So it's used about 60 times a month through our EMS system. Narcan is available in a number of settings now. There's specific funding projects through SAMHSA, the mental health branch of the federal government. It's administered through the Department of Healthcare Services here in California, and it provides free Narcan. And so there's a big campaign to make it more available in schools. It's available through hospitals, emergency rooms, trying to get it out to the public and to those who can best use it. There's some basic requirements for organizations to receive it, but it's mainly around storage and distribution and tracking. So quite a few doses have been distributed. As part of receiving it, you are asked to ask if someone is requesting requesting Narcan, you ask, hey, have you ever used it as a reversal agent? And so it's reportedly, 30,000 reversals have occurred. So how do you use Narcan? Well, we've got Joseph here, our navigator, and so he can demonstrate this when we get through this presentation. But Narcan, it comes in, it's a nasal spray. So just like the nasal spray you would use for allergies or anything, or you may have a steroid nasal spray. It's a similar concept, and so you. It comes in a single-use container. It has a plunger. You put it in your nose, or in the individual's nose, and you push the plunger down, and it releases the Narcan. So the usual dose is 4 milligrams. It does now come in large 8 milligram canisters, which can be beneficial because fentanyl is more potent. So we may need higher doses. You can observe someone for up to 2 to 3 minutes. If you are not seeing a response, then give them a second dose. And you can continue to do that after the every 2 to 3 minutes. Narcan usually comes in packages of 2. So each Narcan spray you use in one nostril, one-time use. 2 to 3 minutes, that doesn't work. You use the other canister in the other nares. It's easy to store, room temperature. After you give it, roll patient onto their side after administering Narcan, because sometimes they'll wake up and throw up. Just a note, dealing with someone who's comatose or not breathing much, the other elements in the differential is, someone could be having a cardiac arrest or could have some other type of respiratory arrest. And so if you're trained in basic life support, CPR, be ready to provide that as well. So, but call 911 if they're not breathing, the rescue breathing, or heart compressions. But try and get help is probably the most important thing to do. Another consideration in terms of Narcan is it's relatively short acting, whereas fentanyl and the other opioids are longer lasting. So even though someone may wake up, they might drowse off again. So again, get help as soon as you can. Be prepared to offer additional doses if you're able. So when you do give Narcan, it's an opioid antagonist. So basically, you're blocking the opioid effect. And for someone who is who has opioid use disorder, who's using it on a regular basis, you can trigger the opioid withdrawal, which is not fun either. So that's where you can get the vomiting as well as diarrhea, nausea, other GI type complaints. They may develop a rapid heart rate and achy, runny nose, sneezing, increased blood pressure, sweating, nervousness, yawning, shivering. These are all signs of opioid withdrawal as well. So as far as resources, again, this came straight from you, so I probably won't spend much time on it. But the county and DBH in particular is responsible for opioid use services for our Medi-Cal population, which is half of Fresno County. It's all supposed to be eligible for others with limited or no resources, and so your websites offer some good information about how to access those services. There's treatment programs available for men and women, pregnant women, so in all ages. Um, and again, it's just more information about how to access services, so I won't spend a lot of time on this. Other resources, in addition, Alcoholics Anonymous, Narcotics Anonymous are really beneficial programs. Again, more from DBH here as well. Some other programs that FCDBH contracts with, and private insurance, private companies as well that do provide treatment programs. But I think it's fair to say that the supply of treatment programs it does not match the need or the demand. Here's some different educational resources that you can access when working with clients. I was going to talk a little bit about, I'm a family physician, so just what's the role of clinicians in terms of dealing the potential dangers of opioids. Seen in terms of prevention, in terms of safe prescribing of opioids. We'll talk about that in a minute. And then the use of Narcan, and then referring to treatment programs and providing medicated assisted treatment. So I was going to talk a little bit more about medicated assisted treatment as well. In terms of prescribing, I think that you think about how did we get into this problem. Not every country in the world has the type of issues with opioid disorders that America does, but we had problems with very high rates of opioid prescribing. Our rates in Fresno County were even higher than they were in the state of California as a whole. But we are seeing the numbers going down. So there's been a real concerted effort to make physicians more aware of the potential dangers of overprescribing opioids. And we could spend a lot of time in talking about how we got into this situation. There was a lot of emphasis on addressing pain as the fifth vital sign, et cetera. So there was a lot of impetus to get physicians to prescribe opioids 10, 20 years ago. But now that pendulum has swung back, and I think we also need to make sure that for patients with legitimate pain that they are being offered pain medications. And when I'm asked, well, how do you decide who should have an opioid? I said, well, I think there should be objective evidence of a disease that's severe enough to justify the risk of opioids that include overdose, misuse, abuse, and death. In California, whoops, let me see. There's if you are when you do prescribe an opioid, you're expected to have a pain contract with the patient. So these need to be renewed on an annual basis. You're supposed to check a database to see whether there's been any other use of prescribing of opioids other than through yourself, or to check for signs of misuse at least every 3 months. There's recommendation to drug test at least annually, urine drug screening. And if you prescribed high doses of opioids, you're expected to prescribe Narcan along with the opioid, or if you prescribe both an opioid with a benzodiazepine, which puts you at higher risk for overdose, you're also expected to prescribe Narcan. It used to be very difficult for physicians to prescribe medications for medication-assisted treatment, but the federal government and the FDA is trying to loosen up, make that a little bit easier. It's still more complicated than it should be, if you ask me. We can write for Norco and Vicodin or Tylenol #3, whatever, without jumping through any hoops. But if you want to prescribe buprenorphine, then yes, you have to sign up through this special program with restrictions on the number of patients, et cetera. So they've streamlined that process to some degree. It's still an extra step that's not required for other opioids. So I just want to talk a little bit about Suboxone, which is the brand name for buprenorphine. Suboxone comes as you can prescribe buprenorphine by itself. It's nice in that you can get it, you can prescribe it you don't have to be in a opioid treatment center such as Medmark or BART. You could do it out of a physician's office. You don't have to have patients come back every day to get their medication. It can be prescribed for up to a month at a time. And it doesn't cause there's less kind of behavioral, cognitive uh, um, uh, impacts from buprenorphine than there are from, say methadone. It's With Suboxone, it's combined with naloxone, uh, so that to discourage people from doing what they do with other prescription medications of grinding it up and snorting it or injecting it. Because if you do with the naloxone there, you would immediately have a withdrawal reaction. You can also get it in monthly injections through the brand name, what's called Sublocade. They come in buprenorphine, naloxone, or Suboxone comes in sublingual tabs. So it can be initiated at home or in the office. And because is a partial agonist antagonist, and it has the Narcan as well. If you take it while you've recently used, you will trigger that opioid withdrawal, and so people get really sick from that. So uh, you instruct patients to wait until they feel like they just really want to use again, have to use again, and start at that point. Uh, Other related medicine, naltrexone, which can be used for opioid use dependence once they've stopped using. It's also used for alcohol treatment, and it's nice in that it can be administered every month. In terms of treatments for methamphetamine, so again, we said, this huge problem here in Fresno County and across the country. Unfortunately, we don't have any medicine. We don't have anything like buprenorphine for methamphetamines. So really, it's more behavioral therapies, cognitive behavioral therapies to help people kind of understand why they're doing what they're doing. There's what's called contingency management, where basically you provide people with some incentives to maintain abstinence. But by providing people with more of a focus or reason for living, is probably the the best kind of long-term approach to methamphetamine abuse, as well as our other substance use disorders. Just a brief word about alcohol. So it gets overlooked, I think, in terms of our substance uses, but is incredibly widespread in our society, as I think all of us know. Cirrhosis, our bodies, our livers can tolerate a lot of injury from alcohol, but then at some point they stop working, and then we really don't have any good medicines anymore. So as a result, people with cirrhosis frequently end up in our emergency rooms. So according to this one study, 13% of all admissions of people who are admitted through the emergency room was related to alcohol. So a huge issue in our society. I just don't want us to forget how important that is, we focus today on opioids. And then just to finish up, I want to talk a little bit about what else can we do as a community. So, providing additional education, awareness, and you see the signs, the billboards about fentanyl in our community. Law enforcement is certainly doing everything they can to prevent the flow of drugs into our community. There was something about someone who had sold fentanyl to an individual is being tried for murder here in Fresno County. So that's another to really um, stress the dangers of fentanyl. There are test strips that are available, but they're not widely available, unlike Narcan, which we are really trying to get out in the community. Having fentanyl test strips are not widely available. They don't tell you the exact amount. They just tell you whether or not there's fentanyl in it. I work at the needle exchange program on Saturdays. A lot of people want to use fentanyl. It's readily available, less expensive. So there's certainly some situations where it's important, where you may not know what you're getting, but there's a lot of people who know what they're getting, and are choosing to use fentanyl. Um, Having treatment programs available. And so again, this is Department of Behavioral Health plays a major role there. We've talked about medication-assisted treatment, but there are a few other things that we as a community can do. One is related to syringe access. Another one that I was just to touch on is we are seeing most a lot of individuals who maybe were prescribed opioids or purchased opioids at some point. They may have been taking Norcos or Vicodins or Percocet. At some point, maybe they don't have that available anymore, or they require higher and higher doses, turn to heroin. And so that is the most common route for that is through injection. So you have a high rates of injection drug use, which leads to infections, hepatitis C, HIV, abscesses. So as a harm reduction strategy, smoking opioids rather than injecting opioids is a safer route, and less likely to cause injury, and to cause the spread of potentially fatal infectious diseases. And we actually are seeing more and more individuals who are smoking opioids rather than injecting. So about a third of individuals with the opioid use disorder that we see at the needle exchange are now smoking asper pipes as opposed to needles. And then I was going to briefly talk about safe injection sites as well. So syringe access in California. I'm going to do this a little different order. Um, so accessing syringes in California, people may legally possess syringes in California, no age restrictions. Uh, uh, you can get these from pharmacies. Pharmacies are not required to sell syringes, and pharmacies have discretion in how many syringes they give to a customer. Um, so needles and syringes need to be disposed of safely after use. They can't legally be thrown in the garbage. So I think one really nice thing about the needle exchange program is they return needles in order to get new needles. So it gets those needles off the street. If you're getting it from a pharmacist, they can also provide you with sharps containers. You're not supposed to be throwing these in the garbage. There are different places you can go. The main places where they accept the needles is fire departments. So um, uh, they're not a number. They're not tons of sites, but our fire departments do offer that service. And this slide just kind of goes over the legal background regarding syringe access in the state of California. Interestingly, the VA also supports syringe access, so I include this kind of as a reference, just to show it's not just crazy California that's doing this. And then briefly talk about supervised injection sites. This is what that means is that it would be a place where someone could, who had an injection drug user, could safely inject heroin or meth or whatever they were doing. There are sites that have been doing this both in Europe, Canada, and Australia since 1986. Why? Well, it's a chance to prevent some of these in more supervised, controlled settings. You can prevent some of these infections, prevent overdose deaths, be available for with things like Narcan, provide other types of services. And this one cost-benefit analysis suggested that there could be considerable savings if it was adopted. Um, This was a study that looked at some of the at uh, at supervised injection sites, and so most of the studies have focused on a site in Vancouver, Canada. So what they found, significant reductions in opioid overdose morbidity and mortality, improvements in injection behaviors and harm reduction, and no increase or reduction in crime and public nuisance. So to having a supervised injection sites. New York City actually became the first city in the United States to create a supervised injection site. So it began relatively recently. Um, uh, and so you can see some of the stats here, the range of ages from 18 to 70. We see that, by the way, at the needle exchange program. It's not a opioid use disorder is not restricted to men or to women or to age groups. You see teenagers, 20, 30, 40, 50, 60 years old. Not too many people older than that. But through all the other decades of life, we see a pretty even distribution, unfortunately. A lot of people are homeless. Uh, and again, so most people were using fentanyl or heroin, but we talked about that. A lot of people are smoking now, but so 65% injecting at this site. Uh, and it's an important statistic. So if it wasn't for this, they would be outside doing it somewhere else on the streets. And they reported the number of times they used Narcan and the responses that they had. They basically, I think the experience in New York has been positive to date. So um, we considered this in California and actually passed in the legislature. It would have authorized pilot programs in San Francisco, Los Angeles, and Oakland for all the reasons that have been noted previously. But it was vetoed by Governor Newsom. So um, it's if we think of opioid use and opioid use disorder as a disease, and as those who are users as victims, and it's much easier to think about that when you're talking about teenagers. But I think the same type of arguments and principles apply to older to adults as well. Then you start to think about what type of harm reduction strategies can you use that benefit not only the individuals and as well as the communities that they live in. I think that's all I had. I'd be happy to answer any questions that you might have. And if not, I think we've got the navigators there. And just to put a plug in for the navigators, connecting people to resources in the community is such a crucial element of really addressing these issues. So people show, what the ERs are one of the most common places for individuals with opioid use disorder to access services. But if you're not there at the time to provide those services, it's going to be really hard to find them later. So the navigators really play a key role. Whatever we can do to better support connecting individuals to programs and as entities, organizations, being able to communicate and doing warm handoffs on patients, I think we'll be better off. I know there's work here in Fresno County on developing an information exchange so that it's easier to for patients with for patients who are identified with social determinants of health or substance use, behavioral health issues, connecting them to resources. Those resources, in a lot of cases, are going to be a Department of Behavioral Health, Personally, I think DBH is probably going to need some more resources if we really get this going, so that there's someone at the other end of the phone who can answer it and really get people plugged in. So, but anyway, I'm glad we've got this network of navigators. Making sure they're part of a coordinated system, I think, is important. But that was a long-winded kind of detour from what we were supposed to be doing. So I'll let you guys demonstrate how to do Narcan.
Thank you, Dr. Zweifler, for your time. Now let's go ahead and see the demonstration from our navigators. We can hear you, yes.
So, Joseph was going to do the demonstration, but he stepped away. He's doing a consultation right now. I'm Stephanie, Substance Use Navigator from Community Regional Medical Center. This is Paola. I'll let her introduce herself.
Hi, I'm Paula, Network Ethane Active.
And then we have...
and my name is Juan. I'm a navigator over at Kaiser.
So we're all substance use navigators at different hospitals. Joseph stepped away. He's the Clovis substance use navigator. But I'll go ahead and try to do a quick demonstration. Okay, so I think I have to stand on this side. So basically, on the box, we don't have a box with us today, but if you open up the box, there's a 1, 2, 3 step instructions on how to administer Narcan. Instruction number 1 is to identify an overdose. That could be whether the patient is already lying unresponsive on the floor, respiration has slowed down or decreased or stopped completely, fingernails and lips are turning blue because of the lack of oxygen, and you could also do a sternum rub. If you're not familiar with a sternum rub, you do a fist-like motion, rub your fist up and down, and that is an uncomfortable motion. The patient should react. If the patient does not react, most likely the patient is going into an overdose or is already overdosed. So once you have identified step number 1, that an overdose has occurred, you go ahead to step number 2, which is open up the kit. Each kit has 2 nasal sprays. They look like this one. This one's a mock one, so it doesn't have medication in it. So there's 2 nasal sprays per kit. Each nasal spray contains 4 milligrams of naltrexone. So you're going to go ahead and hold the nasal spray with 2 fingers. Oh, so like this, and I don't know if you guys were... I don't know if you guys could see, so like this. 2 fingers around the nozzle. And then you insert in either, it doesn't matter which nostril, because both of the nostrils lead up to the brain receptors where the opiates are attached. So let's say we decided to go with the left one. We insert it all the way in, closest to the brain receptors. With your thumb, you see this red button right here? You're going to press and hold it for a few seconds. I believe the package says around, like, I don't remember. I think it's 1 minute. But you can hold it for 30 seconds just to make sure that all the medication has been dispensed into the human body and is traveling up to the brain receptors. So once you held it for, let's say, 30 seconds, you release and you pull it out. Once you release your thumb from the red piece will break off, letting you know that the medication has been dispensed to the human body. If the piece stays intact, it may mean that the medication is still in there, or it's a defective nasal spray. If the red piece stays attached, you could go ahead and try to do another spray. But if it doesn't break off during the second one, then most likely it's a defective nasal spray. Instructions say to wait 2 minutes and administer the second one. Like we heard earlier today, this is a fast-acting medication, so if your patient does not respond, gasp for air, or move a little bit right away, It could be that it's not opiate related. Maybe they overdose on something else like methamphetamine. Methamphetamine is not an opiate. But even if you administer Narcan and if it was methamphetamine related, you are not harming the patient by administering Narcan. Because at the end of the day, the Narcan is still medication. So once you waited a few minutes and your patient does not respond with the first nasal spray, each kit has 2 nasal sprays, so go ahead and open the second nasal spray and do it again. So just whichever nostril, insert all the way in, press on the red button, hold it for like 30 seconds to make sure that all of the medication has been dispensed into the human body. It's traveling up to the brain receptors, detaching the opiates and helping resuscitate our patient. Remove the item, remove your thumb. It will break off to let you know that the medication has been dispensed. Step number 3 on the Narcan box is to call 911 to seek medical attention. Like it was mentioned earlier today, even though you help the patient come out of their first overdose, that does not mean the patient cannot go into a second or a third overdose. And basically that's all 1, 2, 3 steps. We don't have the box. I can't show you how it looks on the box, but it's very simple.